I'd like to first welcome you on behalf of the Association of Black Women Physicians, California Medical Association, Network of Ethnic Physician Organization, and the Golden State Medical Association. And it took all of this partnership to bring this event for you today. And so I'm just very grateful. And so that's who's responsible for this event. My name is Dr. Glenna Tolbert. I'm the immediate past president of the Association of Black Women Physicians. I'm also going to be your moderator today, and I'm also in solo practice in Encino. I talked to you already about the format. Let's talk a little bit also about the programming today. I know I accosted some of our guests, and I already apologized that if I'm a taskmaster today as far as time. So please don't be offended, but we don't have much time, and I really want the meat of the program to be the discussion, because many of us are practicing physicians. We know a lot of the basics, the 101. It's also been provided in your packet. It was provided to you ahead of time. So this is really where we can roll up our sleeves and chat. Questions were prepared prior, and they were submitted to our panelists prior. Because there were about 15 questions that I received, however, obviously we won't have time for 15 questions. So based on some of the interviews I did with physicians, I selected 3 questions. I will present those to the panelists. I'm asking for the audience to hold your comments and your questions until about 4:15, and then I will open the floor up for discussion. Because like I said, again, this is what really the meat of the program is. Let's see. That I talked about housekeeping, flow. Okay. How's audio? How are you all doing back there? Still struggling? You're doing better? Oh, good for you. No? Okay. So let me just give you, I took a few bullet points from, this is something called the Uninsured Project, and they are having a conference call next, or I guess it's tomorrow night. And I thought it was really interesting, their background. And so I just stole a little bullet points from them that said, independent, solo, and small group physician practices are an important piece in California's healthcare landscape. They serve as access points for patients to receive healthcare services. They emphasize personal and relationship-based continuity of care, and they serve the geographically and socioeconomically underserved, and more specifically, solo and small group physicians commonly serve ethnically diverse communities. Recent studies have illustrated that solo and small group practitioners have reduced and lower rehospitalization rates than larger practices. However, it has become increasingly difficult for solo and small group physicians to practice medicine due to financial barriers, administrative demands, and lack of adequate resources. And drum roll, the impact of Covered California. And so that's going to be our segue, and I'm going to introduce our guest. Our first guest, and I've asked our panelists, I'm going to introduce them. I will read their bios, and then please, each panelist, you get 3 minutes to tell us, how do you rock it in this system? How are you significant, so that we can know how to direct our questions. Okay, so you'll get 3 minutes for that. Our first guest, and I just found this very fascinating, Mr. Dana Howard. He is the Deputy Director of Communications for Covered California. He joined Covered California in January of 2013 with a personal commitment to play a part in implementing the organization's historic mission to bring access to quality, affordable health care to Californians. And of course, his bio is a lot longer, but what's also is interesting is that your previous history as a news anchor, I believe, so that was really fascinating to me. So, Mr. Howard, 3 minutes. Could you tell us your role in all of this?
Sure, glad to. Thanks so much. And I was just talking with Brett Johnson, another panelist you'll hear from in a moment earlier today. He was asking, so when did you start at Cover California? And I said, well, it was January of 2013. He says, oh, you're an old timer. And literally, I am, because 2 years ago was when we really were just beginning to launch Cover California. And at that particular time, you could fire straight through the offices of Cover California and not hit anyone, because there were so few people there. And then within a very short amount of time, we had hundreds. And so we just completed our second open enrollment period for Cover California, and it went well. We enrolled about 495,000 folks in this enrollment period, bringing our total effectuated up to hopefully around 1.4 million between the enrollment in Cover California and the enrollment in Medi-Cal, the expanded Medicaid. We have really brought in about 4.5 million folks into insurance, into health coverage in California, and that's really, we think, quite remarkable. It shows that there was truly a demand for healthcare coverage here in the state. Going forward, we have a lot of heavy lifting to do. You might have thought that getting that many people in was a heavy lift, and it was, but bringing in the remainder is going to be quite a bit of a challenge, and it's not going to be simply running broadcast ads on TV and telling everybody to come enroll. These are folks who most likely have been in this culture of non-coverage, a culture of being uninsured, and who have found ways to cope. And so now it will be upon us to demonstrate that there is strong value in having health coverage, and there is as well strong affordability in doing so. That it not only makes sense as far as your health goes, but it also makes sense as far as your financial security and stability. And so that's the message that we really have to deliver to people over this next year and in the years to come, as Cover California shifts away from being an open enrollment event to being year-round enrollment. I think that's my 3 minutes. I heard that mental ding go off. So we'll definitely be anxious to talk more about that.
Thank you. So, in synopsis, what you're saying is that you have a lot of more work that you'd like to do. You'd like to increase your enrollment, and you feel that it's just good health care for the community to have more people enrolled in Cover California.
Correct.
Okay. Our next guest is Mrs. Bonnie Preston, and Berkeley in the house here, because Bonnie Preston and also our other guest, but I'll introduce later, is from Berkeley. Bonnie has over 20 years of experience in health policy, health services, research, and health program development in all levels of government and the private sector. Prior to joining HHS, she worked as an independent consultant, assisting California to prepare for the Affordable Care Act in the areas of workforce development and access to care through telehealth. So I present to you Bonnie Preston, Policy and Outreach Specialist, Office of the Regional Director, Region 9, U.S. Department of Health and Human Services.
Thank you so much, and thanks for having me here today. Since these talks have been drastically reduced, I want to start with where I wanted to end up, and that is that I wanted to come here today to say this is a reigniting of the conversation that we had 2 years ago, right before Covered California launched. I believe we were gathered in Henderson, Nevada, and we were talking about the hopes for these the expanded coverage. And I think that kudos to Cover California for really going above and beyond what people really anticipated could be accomplished in the first years of the Covered California marketplace. But as you know, we're also coming up on the 5th year since the Affordable Care Act started, and it really started with expanding care right away in 2010 by allowing parents to continue their children on health care coverage until the age of 26. So with that expansion and the marketplace expansions and the expansions in Medicaid, we were able to announce last week that 16.5 million Americans who were previously uninsured now have insurance or cover, healthcare coverage in this country, which is the largest change in insurance status since the introduction of Medicare and Medicaid in 1965, and so this is really exciting, and now, so we're celebrating that as Monday marked the 5th year anniversary of the signing of the the Affordable Care Act. So now that we've launched these coverage opportunities and so well in California, and a lot of it couldn't have been done without physician groups like yours. I know that the California Medical Association had received a Navigator grant through Covered California, and the ethnic physician groups, many of them participated in that work. And I really want to thank you so much for all you did to increase coverage to your patients and people in the community. So now that
we're gonna.
We have to go.
Yes.
Okay. So
yes.
it's the beginning of the conversation, because now that the focus is shifting at the federal level for Health and Human Services to improving the quality and better aligning federal incentives to improve quality and affordability of care. And so I really hope that we can engage with all of your groups, because you are at the forefront. You are the leaders who can help us get at the kind of equitable system of healthcare that we want, and we're not going to get there without your leadership in your communities. So we have a new.
I think that's
okay,
great.
We're going to
Thank
cut
you.
it.
Yes.
But I have 2 people in our offices we want to.
Okay.
Engage
Well,
with
you'll
you
have
on.
a chance.
Okay.
So
Good.
thank you so much. It sounds like what you're saying is you're very pleased with the outcome of the expansion of Medicaid, and you're wanting to align with physician groups. And then we'll hear more from you.
Yeah,
later.
not just Medicaid, but all the expansions that were proposed and
Through the
implemented
Covered California.
Through Covered California and other coverage improvements.
Thank you. So I warned you about me.
Yeah.
Yes.
No problem.
Okay. So Bianca, and I had your last name correct before, but I don't know. You know how you get up here and you get a little nervous. So, yeah. So anyway, we welcome you.
Thank you very much.
And Bianca is the director of provider contracting at LA Care Health Plan in Los Angeles, and she just flew in from Australia. So we really appreciate you being here with us.
Well, good day, y'all. So yes, I am the director of provider contracting at LA Care Health Plan, and we're the nation's largest publicly operated health plan. When it comes to our membership, we represent about 1.7 million members. About 800,000 of which are direct Medicaid line of business. We also have Covered California, and in this discussion, we're in a somewhat unique situation in that we work with members as they churn in between the 2 programs, those programs being Covered California and Medi-Cal. In the first year of the program, we did see a large amount of membership shift from one to the other, and we anticipate this will continue to be the case as members kind of toggle between Medi-Cal eligibility and Covered California enrollment. So we're happy to participate in this discussion and address this and any other questions regarding our 5 lines of business, which are Medi-Cal, Covered California, our CalMedi Connect line of business, PASC SEIU line of business, or Healthy Kids. So thank you very much for including us in this dialogue.
Thank you. Very good. And you said something that was interesting. You're the largest
Publicly operated health plan. So we are a organization that was created by the state to manage the Medi-Cal lives in a 2-plan model here in LA County. So there's a for-profit organization, HealthNet, as well as the not-for-profit LA Care. And between the 2 of us and our plan partners, which are represented for us as Anthem Blue Cross, Care First, and Kaiser Permanente, we manage the managed Medi-Cal lives in LA County.
Perfect. Aren't you good? Woo.
Thanks.
Thank you. Okay, Mr. Joe, is it Safran or
Safran, you got it right.
Thank you so much for joining us. Mr. Safran is a senior network manager for PPO Professional and Specialty Networks for Blue Shield of California. So, in other words, contracts, correct?
Correct, yes.
Okay. And Joe's coming to us from Northern California. So, again, we really appreciate you coming down here to the Southern California. Please share.
Thank you. Good afternoon, all. So I also realized a uptick in my heartbeat when I was mentioned we had 3 minutes. My presentation was timing out at about 10 minutes, so I was faced with the dilemma: either really talk really fast and cover everything, or boil it down to its essence. So I chose the latter, and wanted to say in the short time that I have that Blue Shield's mission, we think, is very much aligned with Covered California's mission. Our mission statement is all about providing access to high-quality care at a affordable price. And if you look at the Covered California mission, you'll see that there's a lot of similarity there. Moving to affordable price is a bit profound for Blue Shield. 4 or 5 years ago, our mission was basically provide high-quality care at a reasonable price. Reasonable price to us basically meant at market. But affordable care really means at a price that our members can afford. And through our servicing of various client accounts, such as CalPERS, we heard very scary trend predictions about the cost of medical care increasing, to the extent, if the current trend continues for a number of years, less than 10, healthcare will cost more than the CalPERS employee makes. That's just one small example of the affordability crisis that we see, and we are committed to this. We think Covered California has the same agenda as we do. In my packet, which I invite you to read at your leisure, basically we just summarize some of the things that we are doing to take some of the pain out of this transition. 2014 was a challenging year for us. As Mr. Howard alluded to in the enrollments of Covered California, Blue Shield had the largest enrollment growth in our history, and we've been around since 1939. Wow. And we had over 600,000 new members join us last year, bringing our total membership to about 3.7 million. And while that sounds like a great thing, and we are not bemoaning that fact, that membership growth did pose some challenges to us. Some of the basics that we felt that we did very well, quite frankly, we had some service issues. You know, just the act of getting out an ID card, or being able to tell a member or prospective member if Dr. Smith is in our network or not, all became challenges. So with that as the context, that's why we wanted to share some of the details of what we're doing in the presentation. I want to say here that I think our hearts are very much in the right place. We certainly have a ways to go here. I'm not trying to sit here and tell you that things are great. But from listening to physicians like yourselves, and for instance, Dr. Hector, spoke to me quite candidly about some of his perspectives, and the fact that we have vehicles to develop, if you will, a new paradigm of care. We're very interested in doing that. Probably our largest one.
And I think we'll have
out?
more. Yes, I think
Okay.
we'll have a chance. So it sounds like, if I may summarize, it sounds like your mission, as you said, which is an interesting way you put it, is providing quality products, quality health care at an affordable price for patients, because you found that the price point was becoming, or predicted to be, unrealistic.
That's correct,
Okay,
yes.
thank you so much.
You're welcome.
And so last but not least, from our own CMA, California Medical Association, we have Mr. Brett Johnson. Brett Johnson is an Associate Director for Medical and Regulatory Policy at the California Medical Association. Mr. Johnson primarily works on policy issues regarding the commercial health insurance market, managed care, and healthcare reform, specifically the Covered California. He has presented to physicians across the state of California on various health reform topics beyond exchanges, like provider director issues and emerging accountable care organizations in California. He's also John Hopkins. I thought that was very impressive. John Hopkins, a university graduate. So, Mr. Johnson, take it away, will you? Thank you.
Thank you, and thanks so much for having me. I'll try to be as brief as I can. I'll be brief because I can't really describe myself as rocking much of anything. But
We all rock it in our own way.
I try, but I'm not much of a rocker. So as my bio described, I've been with Covered California since about the third. With CMA since about the third Covered California meeting. So I remember when Covered California's offices were, I think, over on G Street, and they had maybe a dozen folks over there. So I've been advocating on behalf of physicians, particularly solo small physicians, in a lot of cases, and I think we've made a lot of progress on a lot of the issues that are near and dear to solo and small group physicians. Discussed a little bit about some of the networks and directories, and that's been kind of one of the issues that we think Covered California has really brought a lot of things that have been going on for a long time to light. And we see as there's more and more cost pressures, and we totally understand that. And as we start seeing more narrowing of networks, or selectivity in networks, or tailoring of networks, however you want to describe it, we think that we really need to make sure that the regulatory apparatus and that the state can really monitor networks and directories in the way that you have to when you no longer really have any wiggle room in the number of providers you have providing care within a network. And we think we're moving in the right direction on that. Department of Insurance has done a lot. We know Covered California is moving in the right direction on that, and we hope Covered California continues to really keep the focus on ensuring that coverage means meaningful access. So we feel that things are moving in the right direction. We just have to make sure that we're keeping attention on making sure that coverage means care, and I'm sure we'll get into quality and performance rating and all that other fun stuff that physicians love in the discussion.
Okay. Thank you so
That was
much.
sarcasm, sorry.
No, thank you so much. You said a few things that were interesting. You mentioned the narrowing of networks. You mentioned we want to make sure that health insurance is the same as health care, that they're not necessarily synonyms. So those, thank you very much. You said a lot, but those are the things that caught my ear. Okay, so at this point I'm going to pose some questions to the panelists, and as I said, these were questions that were created by physicians. And so we had 15, but here we go. And I'm going to direct this question to, actually all the panelists can comment, but I think I'll start with Mr. Johnson, just because you were the last to speak, and it's somewhat of a clinical question, I think. And actually, even though that I look at it, maybe it's more, let's start with Covered California first. The question is, why can't Covered California patients choose private medical practitioners as primary providers? Mr. Howard.
Well, they can choose a physician. I think what we're looking at is whether they can choose if those physicians are indeed in a network where they can be, where the consumers can have access to them. When you shared this concept with us earlier, I think in general we were a little bit puzzled because the physicians, 100% of them who are licensed, are available to the networks, and so the consumers should indeed be able to have access to them. I think what we really need to concentrate on from a Cover California perspective is to figure out how to make sure that the physicians who are present are indeed available to the networks and available in critical communities. And so I think what you'll see going forward is Cover California looking at ways to be able to do that, whether it's a matter of looking at particular communities, geographic communities, to assess who's present, meaning what doctors are there, and then making sure that when we have dialogue with plans, making sure that the plans indeed have those doctors. The question was a little bit obscure to us because I was trying to figure out: are we talking about a certain set of physicians? Is that what we're talking about? I'm asking you.
I did not, like I said, I did not make the question.
Uh-huh.
These were questions that were submitted.
Okay. And so if that is, I think what we're going to cut to the chase on is why is it that the folks in certain communities, why can't they get a black doctor? Why can't they get a Latino doctor? Why can't they go directly to them? I think that's what I'm hearing.
Because, it's funny you should say that because that is another one of the questions.
Okay.
So that's maybe, and that came from someone else.
Oh,
And
okay.
they formed it that way.
All righty.
Straight down, yeah.
So without beating around the bush and trying to delicately say what needs to be said is that we're going to be looking at that. We're going to look at how many doctors are in black neighborhoods, Latino neighborhoods, making sure that dearth of access goes away. That when you are living in, and I'm just looking at LA here, but if you're living in Carson and Gardena, that you don't have to drive 30, 40 miles to go see a doctor because for whatever reason, the plans don't have the black doctors here. Does that make sense? And so what we start doing is looking at the neighborhoods, looking at the zip codes, and trying to get that aligned to say, well, who is here? And if they're here, working with the plans to figure out, well, do we have these physicians in the network so that these folks everyone has access, and that we don't have black doctors and Latino doctors out there trying to figure out why is it that I can't get my clients? Why is it that I'm not in the network? So we want to see if we can get that balance.
So the question was, why can't Covered California patients choose private medical practitioners as primary providers? And the answer is they can. The part B was, though, that Covered California recognizes, though, that in certain communities, that maybe the underserved communities, the minority communities, that they aren't allowed to contract, or there's some issue, there are some concerns. And the response also is that Covered California is looking at this, but we still don't exactly know the mechanism yet, what that means exactly. So that's still a little ambiguous. Okay. And the next question, and I promise I'll spread the wealth, but time. I want to open it up to the audience who fought the traffic. The next question is, and I will direct this first to Mr. Howard, and then I'm going to spread the wealth around, but it's Covered California question. Is Covered California a private or government program?
Well, Cover California is a kind of a hybrid. There aren't too many agencies like what we have. It is government, but it's a government program that sells a product. And so you don't have that. I mean, the lottery is kind of like that, but it's kind of unique. It's a hybrid. It's a quasi-governmental program. And that's why when it was established, the legislature gave Cover California a lot more leeway when it comes to spending, when it comes to the board, when it comes to determining what the revenue structure is going to be. It gave us a lot more leeway than it would with a regular state agency. So it has that kind of duality of being that it's government. I get my check signed by John Chung or the state controller, and so I am a state employee. However, we are selling a product and operate in much respect with a private perspective.
Thank you. Mr. Johnson, could you comment on that? The
Yeah,
same question. It's the same question.
Yeah, I can. I mean, I can add a little bit to that. I can add.
Thank you.
kind of
Thank you, too.
From CMA's perspective, we think Covered California's position, as well as their model that they're going forward on, which is what they call an active purchaser model, which means that Covered California doesn't necessarily change the way the market looks or the way products look through direct regulations and lawmaking. Whereas other states have said, here are standards for products. Health plan, if your product meets those standards, you're automatically in the marketplace. Covered California's model says not only do you have to meet those standards, but you have to come to the negotiating table, and we're going to talk about what your plans look like and what your premiums look like, and that sort of thing. And that's why we really see a lot of promise in Covered California as an agent of change in the marketplace, because they do have this power
Sure.
of the negotiating table.
Thank
So we believe that they're going to be a major player going forward in kind of what the marketplace looks like and what health products look like, and so on.
Thank you. Bonnie, what do you have a comment to that? Since the question was, is Covered California private or government?
Right. Yeah, no, I see it as a hybrid. I think that the state of California really set it up to be an independent, to have some powers independent of what a state agency would have. So.
Okay. Thank you. The next question is, what are health plans? So we now get the health plans involved here, directing this to you. What are health plans doing to ensure quality patient care is the main objective of their services? And I'd like to direct this question to Bianca first, and then to Joe second.
Okay, certainly. Well, first of all, what we're doing is we're looking at, obviously, pay for performance. This is something that in 2014 focused around 17 different HEDIS performance metrics. So these are standard, accepted, best practices within medical care. And we're looking at them, just like other health plans are, as a metric across the board to identify those groups, in our case, and physicians, that are providing what we see to be standard accepted qualities of care. And this is also data that we need in order to report to the state and federal government in order to ensure continued funding. So we're looking at that, obviously, and we're looking at integrating that more and more into our contracting model so that we are not paying groups that are underperforming the same that we're paying groups that are performing at a higher level. We want to make sure that the payment is commensurate to the level of care being rendered to our members, because at the end of the day, it's going to result in better outcomes. In terms of helping members to navigate through the system in identifying those physicians that are highest performing and those groups that are highest performing, we are looking at using that data to develop preferred provider lists. This is something, though, that we are doing in a very careful manner, and trying not to identify groups as being overperforming or underperforming without giving it a lot of thoughtful consideration, because part of our mission is to make sure that we are maintaining our safety network of providers, hospitals, and physician groups. We recognize that in some of the communities that our physician networks serve, they're going to be facing challenges that are unique to their demographic population being served that aren't being felt in other communities. And we don't want to disadvantage them by saying they're low performing when in fact they were dealt cards that were different than those in other communities. So we are looking at this very carefully. but it is something that is part of our 2015 strategic initiatives and will continue to be part of our focus. One comment, if I could, with regards to a couple of other questions that were already answered. We are looking at mirroring our existing network to our Covered California network.
You might want to explain to the audience what you mean by mirroring.
Certainly, certainly. So, one of the questions was about access to care and members having access to a physician who might be African American or Hispanic, if they themselves are African American, Hispanic, and feel that better suits their cultural needs. And our existing Medi-Cal network of physicians and physician groups, hospitals, etc., already serves that community very extensively. In fact, in terms of developing our Covered California network, we used our existing network where we have quality metrics already in place and have identified groups that are high performing, and we use that network to build our Covered California network. So we do feel like those needs are being met in our Covered California physician and hospital network, as well as our ancillary network. And we use that looking at quality metrics as well in terms of developing that. So that's how with the onset of our Covered California product, we're not only ensuring that member access to care and cultural needs are met, but also quality metrics are in place in serving that community as well.
Okay, thank you very much. So it sounds like what you're saying, the answer to your question in terms of quality is, and those of you who are practicing, it sounds like it's similar to that chart-based system where you check the box. You all are familiar, or the physician quality reporting system. So checking some of the boxes and the parameters are one of the ways. And then also the other strategy is having another product that's outside Covered California for those physicians or practitioners who are already seeing Medi-Cal patients.
And what we are seeing, at least in the first year of the program, is that the individuals enrolled with our program specifically, they've signed up with the Bronze Plan, which for those of you who aren't familiar is a high deductible product. These individuals are incredibly healthy. Because these individuals are signing up for a product that has a high deductible, many of them are betting that they're not going to get sick. They're not going to need to go into the hospital. They're not going to have to pay that, what is it, the $5,000 deductible that's part of the program. And that being the case, the members that did enroll with us, they're majority male, we're finding, majority in the 40s age range. These are individuals previously uninsured. They're not coming to our program from a commercial product. These are just new patients to managed care. This is the first time they've entered into this arena. And the hospital utilization data and physician utilization data we're receiving is so low that when the program first started, we actually were checking our systems and making sure that we hadn't missed anything because they are just so healthy.
Thank you. So I will repeat the question for you, Mr. Safran. The question is, what are health plans doing to ensure quality patient care is the main objective of their services?
So speaking for Blue Shield, which I would categorize our network and our relationship with physicians as a community-based model. We do not employ practitioners. We contract with physician groups and individuals. And I think that somewhat dictates our strategy. We're not a Kaiser in which the physicians are, quote, employed, and you can utilize employment practices to get the results you want. We have to go about it a little bit different way. So we do it in a variety of manners. Some are very basic. In our medical policy, which are the set of kind of rules in which dictates whether or not a service is a covered benefit or not, we are much more now in a point of using evidence-based literature to dictate those medical policies. A good example is in the genomic testing, in which you have these genetic labs out there that are all developing their own proprietary tests sometimes, and sometimes the literature says that one test is better than another. So that is pretty much the basics, if you will, of medical policy, and not anything that is really groundbreaking in that regards. The next two may be controversial, but we do feel these to be more progressive. First off, we are trying to incentivize groups to focus on quality. One example is we are working with some providers in the Ventura and Bakersfield area who have come together clinically In other words, they are not part of the same organization, but they have clinically integrated. We believe that that is a model that could lead to higher quality, and we want to be able that these entities or these relationships have sufficient resources to do what it takes to become clinically integrated. Sharing of an EMR, patient medical home, quality assurance type activities with the other parties as well, is something that we are now trying out, if you will, on a limited basis. If it's successful, I would see that growing. Okay. And probably the biggest example of that would be what we call our ACO strategy. That ACO stands for Accountable Care Organization. It is not the model that you may have heard from Medicare. In our view, it is bringing the three main, drivers of care, physicians, hospitals, and the health plan together, and medical decision making then becomes very much not being given on high by the health plan, but very much more locally developed by those parties. And we've had a lot of growth in that mode, and the model is delivering results both financially and quality, and that's something that we want to expand. We have a very aggressive strategy or goal to significantly increase that. This does touch on the question earlier about primary care physicians, because the role of a primary care physician in a PPO model is one that historically has really been very not developed, if you will. It is true that certainly a contracted PPO physician, if they're a primary care physician, is a primary care physician, but when we think of that, we're actually kind of thinking of in the HMO world, where you have a member card that has a PCP on it, they're the gatekeeper. And in the PPO world, there's been some benefits that really kind of get in the way with that. For instance, in the PPO world, members can self-refer to a specialist without a referral. So how do you develop the role of a PCP in that model? The fact that we don't assign, Mary Jo Smith to, Dr. whoever on the card also in our system poses some challenges. So what we've been developing this last year are what are called patient attribution models, in which using algorithms, you can basically use claims data to determine which of the physicians are really treating the members and therefore are in that role of a primary care. And we expect that that's going to be a necessary part of developing a PCP role officially or formally in a PPO product.
Okay, thank you so much. So it sounds like then your response, there's several things you mentioned in terms of ensuring that there's quality care from your organization. You mentioned evidence-based,
Correct.
but I wasn't sure if that was evidence-based medicine, or is this evidence-based, is this based on medical practices, what doctors are doing, or when you say evidence-based, I wasn't too sure, so I don't misstate it.
Sure. Well, it's specifically relates to our medical policy, where we will determine or the benefit determines whether or not something is a covered service. And that could be, certain kinds of tests, certain kind of procedures, et cetera. And historically, I think it's been, that medical policy has been developed by medical judgment of our clinicians, and because we do employ medical directors, et cetera. But those decisions historically may have been done without published, studies that support the medical policy.
Okay.
And that is something that we are, and the whole Blues are moving much more to more evidence-based, study-based policy decisions.
So they're evidence-based policy, not, as we
Yes.
physicians, we think about evidence-based medical cares, randomized, controlled, vigorous. So just
Right.
being clear, so we're on the same level. Okay, thank you very much. So we're coming to that time now where I can give up the mic pretty much, more or less. And I want to open it up to the audience. So any questions that you all have, any comments that you want to this is the time to do it. In summary, though, the questions for anyone who walked in, the questions and briefly the answers that we went for the previous 30 minutes were, number one, the question was, why can't covered California patients choose private medical practitioners as primary providers? The answer was they can. However, we did mention that there is the issue of restricted networks that still needs to be worked out. Is Covered California a private or government program? It's a hybrid, is the answer from our panelists. What are health plans doing to ensure quality patient care is the main objective of their services. It's more, many policies are being put into place, some things that are similar to the metrics, such as you all know, checking the boxes that you've checked this and that or the other. And then the other issue that came up also were minority and underserved patients being able to see the doctors that they want to see, because many of the ethnic physicians have had their patients removed from them because of Covered California and put into different practice settings. So that's something else that we also mentioned, and that has been a problem for access for the patients and also impeding the businesses of the ethnic physicians' practices. So now I'm going to open it up. Dr. Sherrod, do you want the mic here?
Thank you. I'd like to commend the panelists on their discussions and answering the questions. And thank you so much for taking your time to come down and discuss this with us. I'm a pediatric infectious disease specialist, not in practice anymore, but I'm really, and I know this is going to sound a little bit retarded because everybody probably already knows the answer to the question, but I'm trying to get my head around the structure. And if I said that Covered California is the vehicle for administering the Healthcare Affordable Act in the state of California, would that be correct?
Yes.
And if so, then how does Medi-Cal and Medicare fit into the Covered California? And then what is the California's benefit exchange? How does that fit in? And then would you say then that Covered California is a health insurance and Blue Shield is one? Are they considered equal competitors? And then how does Blue Shield get into Covered California? Or do they even deal with it? And then we talk about LA Healthcare and HealthNet,
Okay.
then they would be considered plans.
All right. So
I'm just trying to get some
I'll
understanding.
do a quick
about
Cover
all these new
California 101.
terms.
So Cover California, and thank you, that's a great question. Cover California, when you say is Cover California administering, I look at Cover California, Cover California does as well, as a partnership between the exchange and Medi-Cal, which is the expanded Medicaid for the Affordable Care Act. So the Affordable Care Act went out and said, states, you set up your exchanges if you like. If you don't set up an exchange, we'll set up one for you and operate through the federal government. States, we want you to expand Medicaid. We want you to expand it to folks who are adults without children. Because previously, the only way you can get Medicaid was that if you were a mother with some kids, was essentially it. That's not just it. It is just essentially it.
For
So,
older Americans.
and older. The primary one was that if you were adult and childless, you were not eligible for Medicaid. So now men can go out and get Medicaid if the expanded Medicaid, which is called Medi-Cal here in California. And those folks who are eligible because of their income are eligible to be in Medi-Cal. That's 138% of federal poverty level and below. That's Medi-Cal. Above 138% FPL, you're going to be eligible for Covered California, and you'll be eligible for subsidies within Covered California up to 400% of FPL, of federal poverty level. Your children will be eligible for Medi-Cal as well, up to, I think it is 250, thank you. And so that's it in a nutshell. Covered California is what's called an active purchaser. That's a role that it decided to take on as an active purchaser, meaning that it is going to negotiate with the health plans to come up with the best plans offering the best value for consumers. And so we will work with Shield, and we will work and negotiate as well with Cross, all the plans in there. They submit a bid or an application to come in. We don't just take any and everybody. Some states do. They come in and there's more than 100 different plans to choose from. Covered California looked at that and said, that doesn't make sense for the consumer. How is a consumer who's never had insurance going to come in and try to discern between dozens and dozens of healthcare plans what's the best option for them? So Cover California says, come one, apply, we'll review what you're offering, and then we will select those and enter into a negotiation with those to come up with the best value that is as well meeting what we call our standard benefit design, meaning that what you get with Shield, you're going to get with Kaiser, you're going to get with Cross, you're going to get with Health Net, Sharp, and so on. So that when the consumer comes in, they are seeing an apples to apples comparison of what the benefits are. The difference is what's your network and what's your price. And those will vary between the plans. Bonnie.
No, it's perfect.
Oh, thank you. I haven't heard that one before, but I
Another
appreciate it.
thing that consumers need to check is what drug formularies are in the different plans. too.
Correct. Correct.
So just to add to that, as I look at it as well, Covered California is a marketplace where there may be private insurers participating. As Mr. Howard mentioned, we contract with the state, if you will, to provide a set of insurance responsibilities, basically, right? You delegate the responsibility of running an insurance product to the participants in that. But in terms of a marketplace, there's a website where the potential member can go make their choices, and that could be Blue Shield or it could be any one of the other participants as well. And that is, I think, what has caused a lot of confusion in the market in the first year, because there was confusion as to, do I go to Blue Shield to get the product, or do I go to Covered California? And the reality is they could do either. So I wanted to clarify that in our view, is also a real key role of Covered California, providing a marketplace for folks to purchase insurance.
And you are an insurance agent under Covered California.
Correct.
Okay,
Yes.
I
Yes.
got